Hi, Matthew Holt, another THCB quick bite here. I'm here with Ogi Kavazovic, who is have I got that right, Ogi? Who is the CEO of House RX. Ogi, you've done a lot of different things, including outside of in tech and outside of healthcare, including a quick stint at Flatiron Health, where you got a baptism of fire into the world of healthcare technology, data, drugs, and God knows what else. And you decided to move that we have a serious problem in specialty pharmacy. A lot of people don't know that specialty pharmacy, all those injectables and other drugs that sort of get associated with the clinic, is a huge market, probably bigger than standard RX. What's the problem with it?
It is bigger than standard RX. And by the way, good job with my name. You actually done a lot better than most people recently. So specialty pharmacy is really interesting in a few different ways. One, most people don't realize it exists, and the reason is it only impacts about 5% of the population. So for 95% of us, we don't interact with this market. So it sounds like very niche, but it's not niche. When you look at the dollars, it is bigger, about $250 billion and growing almost 10% year over year than all of the Rite Aids and Walgreens and the CVSs you see out there combined. It's this, and specialty really is a euphemism primarily for expensive. I think that the Medicare definition is anything above $800 or so a month per patient gets into the specialty tier. And then the other part of the definition is it's more, you think of chemotherapy, oral chemotherapy, think of injectables for rheumatoid arthritis. You're also dealing with a serious disease, and these medicines that you're using often have serious side effects and that need to be managed. So extra care needs to be taken when administering these and when prescribing and administering these drugs. So there are extra follow-ups with the patient, making sure they're okay a few days after they start taking, make sure they take it on time, all this stuff. So especially pharmacy industry, sort of sprung up because the retail pharmacies, the CVSs of the world, just did not have these capabilities. Now this market is, interestingly, as well as competition is working in the regular pharmacy, which is you go to New York City, you have a Walgreens and a Rite Aid and a CVS literally on the same catty corner from each other, and you're trying to, you have so much choice, it's almost overwhelming, and they're all competing for you as a consumer. So the experience is very seamless and easy. There's the opposite of that in this bigger market called specialty pharmacy. Out of the $250 billion market, 4 companies control 88% of it. And the only way of delivering is on a 2-day FedEx or UPS from somewhere in the middle of the country via mail, which has all kinds of logistical issues and all kinds of coordination issues. And on top of that, you need to get extra authorization and prior authorization from your doctors and extra paperwork that you need. So you need to basically, what I like to say, if you go to a doctor and you get prescribed a specialty medication and you walk out with that prescription, good luck getting it.
Right.
You can't just walk into a CVS and get it. It then begins a long process of sort of bureaucracy and calling people and trying to figure out how to get yourself a medication, mostly being quarterbacked by a patient. And the last thing I'll say is the irony of it is that usually, as I said, if you're getting prescribed a specialty medication, it means you're probably sick and battling a serious disease. And so it's those among us who are battling the most serious disease are having the hardest time getting the medication that they need, which is a huge irony, I think, in American healthcare. And this is the problem we're trying to solve.
And just the four big guys are all owned by insurance companies anyway, right?
Yeah, that's the other thing. Yeah, exactly.
There's a bit of a conflict of interest.
You walk out with that script, and they say you got to go to CVS, and they say we don't carry this. And you ask, well, how do I get it? And they say call your insurance company, and your insurance company will tell you, be like, oh, don't worry, we're also a pharmacy. Let me transfer you to our pharmacy department, which is just a call center somewhere. You don't even know where. So you can imagine, and it's just a completely different DNA. So the insurance company, DNA company, which are actuaries and running crunching numbers and rebates and all this kind of stuff, are also trying to have this like patient care culture, and it's just not their DNA. And so you quickly learn that the only way you get this medication is from your insurance company directly.
So your approach at House RX is to work with the actual clinics who are prescribing, delivering the care. I don't know how much of the specialty pharmacy happens sort of in the clinic, or sort of the person's been treated by the clinic and they're managing rheumatology or cancer or what have you. There's obviously outpatient infusion, etc. And there's home-based
Yeah.
delivery. How does that work, and what's your solution?
Yeah, it's a great question. I mean, an enormous amount of care happens in independently owned clinics in the U.S. I mean, rule of thumb in U.S. is it varies by specialty a bit, but 50-50 in a hospital setting and 50-50 in these sort of independently owned clinics. And this, I think, this, as an aside, this independent segment is incredibly crucial to the healthcare system as a whole. For it to remain in existence and separate from hospitals, because hospital prices for care are just tremendously high because they have all this infrastructure they need to get reimbursed for and so forth. And they also have monopolistic powers in particular markets, so they have the ability to sort of really charge an arm and a leg. So the counterweight of that is having these independent clinics. So the good news is as much as 50% of care happens through these independent clinics. And if you're getting a specialty medications, the overwhelming majority of it has to be prescribed to you by a specialist, not by your sort of primary care physician. So you have to either see a specialist in one of these clinics or a hospital to get that prescription, to get that treatment. And so that is the place to go to look for these patients. And so I mean, what we're doing is, for both cost reasons and for medical reasons, we're doing what's now known as a medically integrated pharmacy, meaning the same team that is diagnosing you, taking care of you overall medically, is also the one taking care of because the specialty treatment is so integrated with your overall treatment that the drugs are the treatment for for these specialty diseases, that they need to be managed carefully. The side effects need to be managed carefully. So it makes a lot of sense for the medical team that is taking care of you to help you navigate through the administration of these somewhat intense medications. And so you mentioned my Flatiron experience. One of the things we noticed there, my co-founder is also from Flatiron, a bunch of us come from there, and other companies as well. One of the things we noticed that oncology clinics, cancer clinics, over the last 10 or 15 years were the first to do this, because they were dealing with life and death, and cancer so serious that they could not afford to have the patient get the rigmarole around with bureaucracies and being on the phone waiting for medication. They really needed to have full control of the treatment. And so they quickly figured out how to pull in essentially a mini pharmacy within their clinic. So they can treat the patient holistically, including the self-injectables and the orals. And over the last decade or so that they've been doing it, the track record has been tremendous. The adherence rates, the time to fill for patients, the outcomes, the clinical outcomes as a result of this integrated model has just been proven to work very well. And so what we're doing is say, look, if cancer clinics are doing it, and not all of them are doing it either, a lot of others need help doing it, why don't other clinics and other specialties do the same? The model works tremendously well and the patients love it. And so what House RX is essentially, it's a technology-enabled service to help clinics quickly bring in the pharmacy services as part of their offering and integrate it into their model, so they can serve the patient more holistically. So we provide the technology, we provide the pharmacy techs, the pharmacists, the distribution, supply chain that you need to figure out in order to purchase these drugs. There's a bunch of things you need to do that clinics just don't have the time or the manpower or the industry knowledge to do. So we take care of all that for them and help them integrate the service. Our big vision is that for most specialty clinics, for this to be the new normal, for most specialty clinics around the U.S., and they're everywhere, every state, every town has them, to have an integrated pharmacy service as part of it, because it's a better cost structure and it's a better patient service.
So there's one thing you didn't mention, which of course is a big deal, which is if the insurance company has its own pharmacy, how do you?
Well, that's not a big deal.
That's not a big deal. How do you make sure that you get paid and that the that this alternative that you're now building, so the especially
It's
pharmacists,
a huge issue.
Can now go this can actually make sure that the patient gets covered and gets paid and doesn't get around by the payer.
Yeah, absolutely. I mean, it's a great question. We're only partially successful so far, and then we're betting that this will change over the next year. Part of the bet for HouseRx is that what's currently happening, which is that, you know, for a lot of insurance companies, if you're, let's say, with United or with Cigna or with Aetna, they will just say, yes, you can get this medication, but you can only get it from us. You are not allowed to go to any other pharmacy to fill it. So, i.e., the patient is not given the choice. And one, this is obviously problematic for a business like ours because we cannot serve those patients. If that patient walks through the clinic door, they have to fill it, so we cannot serve them. But it's also problematic in general because what that leads to, as I mentioned earlier, that leads to a lack of competition for these patients. So the experience these patients, because they're captive to their insurance company, that insurance company has no incentive to iterate on and improve on the customer service. Because if they did improve their customer service, it doesn't lead to more patients. The way they get more patients is by winning RFPs with employers. And that's how they get to more patients, not by improving the service, because the patients doesn't have a choice in the matter. Anyway, the way we're getting around it is, luckily and smartly, I think anything government paid, Medicare in particular, has any willing provider statute. And so, you know, they require that if there's a provider, essentially they enforce patient choice. So if a Medicare Advantage or Medicare Part D patient wants to fill their prescription, they can fill wherever they want. And the government ensures that they have that choice as part of their programs. We're now starting to see a lot of states enforcing this as well on a state level. And I think it's just the right. It just, you know, this integration between insurance and specialty pharmacies has had a long run, and a lot of people are starting to realize all the negative, unintended consequences of that, frankly. I think the market is going to change. In the meantime, we're primarily serving Medicare Advantage patients. So it's basically 1 in 3 to 1 in 2 of the patients that walk through the door we can serve. The other 2 we can't. The other population we can, but we're hoping as time goes on here, more and more of that will be opened up.
Right, and I think I noted that you guys, when you started up, had Olivia Webb, who has that blog, who talks about her experience with this, which is got some press.
Yeah, actually, her article had a big influence on me.
Yeah,
it really did. As I was researching this area, as part of my research, I read her article, which then had links to patient stories, and I sort of went down the rabbit hole,
right,
and all the links. And when you start reading the patient stories, and you can Google, I mean, if anybody, you know, to your audience listening, just, you know, to take our word for it, and you can just Google specialty pharmacy patient experience, and you will see stories as fresh as this morning,
right,
of patients who are, again, battling serious disease, just frustrated, trying to get their hands on this medication. There's so many obstacles, and by making it just from a thematically, by making it, part of it is just that the team you're interacting with is somewhere in the cloud over there, impersonal. Every time you call, it's a different person, right? You know, a lot of those problems we just know intuitively it's different when you're calling Sarah at the local clinic and be like, hey, I still haven't received your medication. And Sarah, I just saw you yesterday. I was just there. And you have that human to human interaction. So when our patients call in to check on their refill, to check on their status, 9 out of 10 times they're talking to the person they already met. Right. And that's just the difference between a centralized behemoth and a decentralized local model, right? And I think we believe at HouseRx that care should be at the edges, at these local, performed locally by a team that you trust and know.
So the last question I have for you is that part of the issue, especially pharmacy, is that the manufacturers of these drugs are charging so much for them. There's a lot of controversy about that. Do you think that what you're doing is going to have any impact on that, or is that whole thing about just the cost?
You know, it's great to mention. We're actually talking to them, and I got to tell you, they've been great partners in this regard. I think a lot is it's a whole nother, I think, podcast we could do about drug pricing and so forth. It's really interesting. A lot of it is just being painted with a broad brush of these prices are just expensive. Actually, there's a lot of discounting happening to these drugs. It's just that we don't see it as patients. It actually goes back through the PBM world. And so some of these drugs I've learned as we went down this drug, there's drugs that has a really, really high sticker price, has as much as a 70% rebate on it. But nobody knows that rebate exists. That rebate goes to the PBMs. Right. And so the actual cost of the drug is a third of what we see that actually goes to the manufacturer. But because of the system is so convoluted and there's so many inadvertent consequences of it, their system incentivizes the manufacturers to put as high of a retail sticker price on it as possible, because they know when it goes through the whole system, they'll only get, I don't know, some fraction of it. And so there's a lot of optically it also looks strange, but certainly they are expensive. I'm not trying to say they're not, but just saying it's quite complicated. But what I can tell you is in our conversations, now that we're getting to scale and we're having, we found them to be very engaged, really interested in what we're doing, and willing to engage with us and looking for ways to save money, especially out of pocket portion for the patients. There's a lot of sort of assistance programs and so forth. So far, the big pharma have been pretty good partners to us.
Interesting. Yeah, I mean, the people are figuring this out. We're now starting to see the first biosimilars come along, and there'll be a lot more investigation into where does the money go and how much should it be. And there was this big ProPublica piece just on the college student who died super expensive drugs, but and using a lot of them. And I think that we can't keep spending the amount of money we're spending on these drugs as a nation without really digging into this a bit, and hopefully we will do shortly. All right, just to wrap up here, Ogi, give me the state of play of the company. You raised about 30 odd million early last year from the Bessemer.
We hit 2 rounds. We did a 5 million seed and a 25 million A. Bessemer led the A together with first round.
Where are you in terms of number of people, number of clients? How do you define sort of the activity of the state?
Yeah, we count physicians that are used on our platform. We count so we're about almost approaching 70 employees. We're a fully remote company and across 17 states. We have about 24 clinics currently working with us. We just mind you, we came out of stealth mode last March, so not even a full year.
Right.
We got a couple of dozen clinics and nearing 200 physicians, specialty physicians. By the way, these are sort of hard to find. There are not that many of them on our platform, which is quite a big number in 1 year, and scaling fast. I just give you a sense. Maybe none of those numbers are sort of inside baseball. I'll give you a sense, like the amount of scripts that we're dispensing via our various different clinics. We're not sort of fully up and ramped up in all of our clinics, but we're projecting, let's see, by the end of this year, we're going to be probably in the vicinity of $500 million being dispensed through our network. That might give people a sense of the scale we're starting to get to. In a relatively short period of time. So yeah, it's the model has been resonating in the market. A lot of these clinics get the need immediately. We start pitching, within the first 2 slides, they're like, yeah, this is a problem. How can we they're like eagerly want to jump to the end of the deck. And they're very, they really like this idea of us helping them bring this in-house so they can sort of cut out, sort of simplify the process for themselves and for the patients.
Fantastic. All right, and so you said $500 million run rate this year for scripts, and you said it's a $250 billion market, so you have somewhere to go.
Totally. Thanks for reminding me of that.
All right, always good to think about the TAM and the SAM and the actual revenue.
Right, that's right. I mean, it's an enormous market.
Right.
So I find that exciting. There's so much runway for us to go after here.
Fantastic. I've been speaking with Ogi Kavazovic. I've got you. Didn't mangle name too much at the end there. Ogi is the CEO of House RX, which is a brand new approach to specialty pharmacy. And Ogi, thanks for coming on THCB.
Thanks for having me. It was fun to have you on. To be on. I mean, thank you.